So now we'd like to discuss about the clinical uses of opioid analgesics. So the most important indication for giving an opioid, of course, is analgesia. So it's usually used for moderate and severe kind of pain. So it can be given through many ways. You can give in the acute setting, of course, it's usually given parenterally, intravenous route, and you can sometimes, in other conditions, you might give oral formulations, syrup, for example, or it can be buccal, or also you have suppositories. Okay, and then it can also be given to suppress cough. Example is codeine and dextromethorphan. Okay, and then can be used for treatment of diarrhea. So we have what, for example, loperamide for treatment of diarrhea, and then it can be used for acute pulmonary edema, APO or APE. So acute pulmonary edema, when you give morphine, for example, parenterally, it may be useful because of its hemodynamic actions, and also because of probably its calming effects can contribute to relief of the pulmonary symptoms. And opioids are also used preoperatively as a pre-op med, and also as can be given intraoperatively as adjunctive agents in balanced anesthesia. And high-dose IV opioids, example morphine and fentanyl, are also often used. They are also commonly a major component of anesthesia for major surgeries such as cardiac surgery. And also opioids are used for opioid dependence. So methadone, one of the opioids which is longer acting, so it's used in the management of opioid withdrawal states and also in maintenance program for addicts. So most the toxicity of most of the adverse effects are just predictable extensions of their pharmacological effects. So if we understand their pharmacological effects, we are able to guess what are the adverse effects that can potentially happen with giving opioids. So overdose, for example. So two components of toxicity is overdose and also drug interactions. So for overdose, when you see a patient with a triad of constricted pupils, small pupils, and they are comatose, and they have respiratory depression, their respiratory rate becomes low, from 12 becomes 5, for example. So when you see these three, then you have to promptly think of opioid overdose, for example, overdose with heroin or morphine or others, and this will require a stat IV naloxone. So you have to give an intravenous naloxone, which is as mentioned in the previous lecture, previous series, that this is an opioid antagonist, which is used to reverse the effects of opioids. And sometimes ventilatory support may be needed in such cases. So drug interactions, the most important drug interaction is, of course, CNS depressants. So this are drugs that can depress the central nervous system, such as alcohol, sedative hypnotics like benzodiazepines, such as diazepam, midazolam, and others, anesthetics, and also antipsychotic drugs such as risperidone, olanzapine, haloperidol, chlorpromazine, and others, and also tricyclic antidepressants, and also monoamine oxidase inhibitors. This should be avoided in patients who are on taking opioids, whether for an acute, especially for if they are on chronic opioids. In the acute setting, of course, sometimes you don't have time, or you have no option but to give an opioid due to the severe pain. But in the chronic setting, then you might want to check first before you start giving them an opioid if they are on these drugs. Okay, you might need to caution them to stop taking ethanol for a few hours or days, depending on the half-life of the drug. And concurrent use of some opioids with the monoamine oxidase inhibitors may increase the incidence of hyperparexic coma. This one especially with meperidine, and in some patients, again meperidine and also some other drugs like fentanyl has been implicated in causing serotonin syndromes when used with the serotonin specific reuptake inhibitors, SSRIs. The SSRIs which are mainly used for depression, like fluoxetine, fluvoxamine, etc., sertraline. Those are the SSRIs that when patients are on these drugs, you might want to be a bit cautious when you start them on opioid analgesics. Next, we go to another sub-classification of the major drugs in this topic. So they are the agonist-antagonist drugs, such as buprenorphine, butorphanol, and nalbuphine. So when we talk about the analgesic activity, it varies. These drugs, the analgesic activity varies, but definitely it's less than of strong full agonists such as morphine. So they are not the first choice of drugs for treating pain. Okay, we can also talk about them in terms of their receptors. So, for example, buprenorphine is a mu receptor agonist. Okay, mu receptor agonist with weak kappa and delta antagonist effects. So buprenorphine acts as an agonist on the mu receptor, and it antagonizes the kappa and delta receptors. So these attributes can potentially lead to reduction in the pain-killing effects, analgesia, or also can potentially precipitate withdrawal symptoms because of the antagonistic effects. So you can precipitate withdrawal symptoms, which is not going to be nice when taken by patients on full mu receptor agonist. So, for example, if the patient is on morphine, for example, or methadone, or just he's abusing heroin daily basis, for example, and then if you suddenly give buprenorphine for acute pain or due to some other conditions, this might lead to a withdrawal. And buprenorphine has a long duration of effect due to its strong binding to the mu receptors. So the agonist antagonist drugs, they often cause sedation at analgesic doses, and you might see physical dependence, but the abuse liability is less than full agonists. Okay, patients who abuse morphine, fentanyl, methadone, they are much more likely to be patients who are on long-standing fentanyl and morphine and those other drugs are much more likely to develop physical dependence when you compare them to patients who take buprenorphine. So opioid antagonists, this is a potentially life-saving drug. Naloxone and naltrexone are pure opioid receptor antagonists, and they have greater affinity for the mu receptors than for other opioid receptors. So they are not that these antagonists are not bothered too much with the delta and kappa receptors, but they attack the mu receptors. They have great affinity for the mu receptors. So this is a major it's used mainly in the treatment of opioid overdose. Okay, it's given intravenous, and naloxone has a short duration of action, about 1 to 2 hours, and you might need to give multiple doses in cases of opioid overdose. For example, you might give the first dose at 8 o'clock in the morning. Patient comes with overdose, and then at 9 o'clock you want to give another dose, and then 10 o'clock maybe another dose. So you can titrate and you can see monitor the patient according to the pupil size and other things, and once the pupil size has decreased and patient is more aroused and no more respiratory depression, then you might want to taper down or stop giving naloxone. Okay, that's all for the opioid analgesics series of lecture. Okay, thank you.